This presentation will cover the topic intracranial hemorrhage, specifically non-traumatic subarachnoid hemorrhage, as its features are slightly different from other types of brain bleeds. Only 3% of strokes are non-traumatic subarachnoid hemorrhages, most commonly due to ruptured saccular aneurysm. Prevalence is 1 to 2% of the population, but incidence of rupture leading to hemorrhage is 6 to 10 per 100,000 annually, so most aneurysms remain intact. The largest risk factors are smoking and hypertension. 20 to 35% of the population smokes, 35% of the population has hypertension, and only 48% of those cases are controlled. These risk factors, combined with natural aging of vasculature and genetics, leads to weakening of the cerebral vascular endothelium, and it forms a saccular aneurysm. Rupture of this aneurysm causes leaking of blood into the subarachnoid space. The most characteristic symptom is a severe headache. Mortality is around 50%, and complications can be profound. It's usually found in persons 40 to 60 years old, and the risk of rupture is highest in those over 60 years old, especially after exercise, if the aneurysm is greater than 5 millimeters, and aneurysms that are located in the posterior arteries. Signs and symptoms include severe sudden onset headache, often described as, quote, the worst headache of my life. This pain may either represent the sentinel headache, which is kind of like a warning headache. It's due to a small leak of blood, or it may represent the subarachnoid hemorrhage itself. If it is due to the hemorrhage, the headache may be associated with nausea, vomiting, loss of consciousness, and meningitis-like symptoms such as nuchal rigidity. Studies show the sentinel headache may occur as early as several weeks prior to rupture, or just between 5 to 20 days prior to rupture in a large proportion of patients. Therefore, in patients with a history of migraine who present with atypical pain, it is important to investigate other causes of new onset pain. There was a case study with a patient who had a history of migraine whose sentinel headache manifested only as unilateral orbit pain. This patient had a known 8 millimeter aneurysm at the internal carotid artery posterior communicating artery bifurcation that had previously been diagnosed with MRI, but because it remained unruptured, the headache was mistaken for a usual migraine. It was actually her sentinel headache. 11 days later, the patient presented with a similar headache, this time accompanied by nausea, vomiting, and neurological symptoms. She was admitted to the hospital, and a CT of the brain revealed subarachnoid hemorrhage. So for physical exam, first assess patient's airway, breathing, and circulation. The patient may present with focal neurological deficits such as nerve palsies, hemiparesis, aphasia, and vision loss. There may be hemorrhage and disc swelling noted on fundoscopic exam, as well as nuchal rigidity and decreased level of orientation. Appropriate consults include neurology, interventional radiology, neurosurgery, and neurological critical care. The most commonly used scales to grade the severity of hemorrhage include Glasgow Coma Scale, Hunt and Hess Scale, and the World Federation of Neurological Surgeons Scale. The Glasgow Coma Scale has the strongest correlation with health-related quality of life. The Hunt and Hess Scale grades the severity of aneurysm by stratifying the symptoms on a scale of 1 to 5, the lower end of the scale correlating with more mild symptoms such as slight headache or nuchal rigidity, and the higher end correlating with more severe symptoms such as coma. The World Federation of Neurological Surgeons scale comprises both the GCS and the severity of motor deficits on a scale of 1 to 5, with the lower end of the scale indicating a high GCS score, along with an absence of motor deficits. These scales are often used simultaneously to predict clinical outcomes and gain a more comprehensive understanding of the patient's risk for complications. The initial diagnostic imaging study of choice is a non-contrast CT. The sensitivity of CT is 98 to 100% for detection of subarachnoid blood within 12 hours of symptom onset when compared with lumbar puncture. In the above image, you can see the diffuse star-like pattern of blood within the subarachnoid space. This is going to be the most classic and common pattern of bleeding that you will see on CT, but it's not always this much. It can be much smaller and localized in some cases. The CT may be followed by digital subtraction angiography if the CT is positive or if it's negative but a strong suspicion of subarachnoid hemorrhage persists. Lumbar puncture will show elevated opening pressure, increased red blood cells, xanthochromia, as well as elevated levels of inflammatory markers such as TNF-alpha, selectins, and neutrophils. Lumbar puncture is usually performed if the CT is negative or unequivocal and a strong suspicion persists. The patient may or may not have an increased erythrocyte sedimentation rate, D-dimer, and fibrinogen, which are associated with a worse outcome. The differential diagnoses for subarachnoid hemorrhage include other types of intracranial hemorrhage. These listed are other types of subarachnoid hemorrhages, and they may be due to trauma, saccular or non-saccular aneurysms, arterial dissection, vascular malformation, or tumors. The differential diagnosis can also include drug toxicity, meningitis, encephalitis, and primary headache syndromes. The suspicion of subarachnoid hemorrhage may be excluded if the CT is found to be normal and there is no xanthochromia or few to no red blood cells in the CSF. The two main types of treatment are microsurgical clipping and endovascular coiling. Patients should be transferred to a neurocritical care unit where blood pressure, fluid status, fever, and glucose will be controlled. Patients may receive sequential compression devices or unfractionated heparin for DVT prophylaxis, as well as nimodipine to prevent delayed cerebral ischemia. The mortality rate of subarachnoid hemorrhage without intervention is around 45%. For those who undergo endovascular coiling or microsurgical clipping, the rate decreases to 2.6% and 1% respectively. Neurological complications include hydrocephalus, cerebral edema, seizures, delayed cerebral ischemia, and rebleeding. Upon discharge, patients should be educated regarding smoking cessation, blood pressure control, and decrease of animal fats, as well as other unhealthy foods from the diet. For patients with known asymptomatic aneurysms less than 7 millimeters in size, periodic MRA imaging and follow-up with a physician is appropriate. And these are my references. Thanks, guys.